Hello there and welcome back to Morning Express. It is Monday, the 28th of July. It is now 8:26 a.m. and we want to get into our conversation, your health. Very important that we do every Monday to have different conversations on different subjects that touch on your health, conditions, diseases. Today we're talking about leukemia, and joining me in studio is Dr. Ruchika Colley, who is from the clinical pathologist at Lancet. She's a clinical pathologist at Lancet. Thank you, Ruchika, for joining us this morning. Let's start by talking about what leukemia is. For many people, they've heard about it. Sounds like this huge, scary thing. What is it?
It is actually a blood cancer. So what happens is that the bone marrow produces blood cells of different varieties, 3 main varieties. So in leukemia, you have replacement of these normal cells by what we call blasts or leukemic cells, which are immature cells in the bone marrow. So they produce at a rate much higher than normal cells, and so they take over the bone marrow machinery, and as a result, the normal cell production is reduced. You start getting symptoms of recurrent infections, easy bleeding, and as these leukemia cells proliferate, you now start seeing them in your bloodstream as well.
Okay. So what makes this happen? What causes it?
There are very many different types of leukemia. Unfortunately, we don't know the exact cause of all of them. There is one type of leukemia that we have identified the cause for. It's called chronic myeloid leukemia, and as a result, now we've been able to come up with definitive treatment for it. But for the other leukemias, we have theories. It could be environmental, it could be genetic, it could be diet. We're not very sure yet.
So you've talked about one that you have cure, you know the cure is known for.
Yes.
What are the other types?
Now, leukemias are broadly classified into acute leukemias and chronic leukemias. Under the acute leukemias, there are 2 main broad classifications again, the myeloid leukemias and the lymphoblastic leukemias, which are further subdivided based on how mature or immature the cell is. Then we have chronic leukemias, which again are of different subtypes, and one of them, the chronic myeloid leukemia, is the one that we now at least know what causes it. We've been able to identify that.
Which one is the most dangerous? Or are they all equally bad?
Leukemias, depending on the type. Acute leukemias generally tend to be worse than chronic because, as the name suggests, they're acute. Symptoms develop much faster than with chronic leukemias.
Okay. Take us through the symptoms. So somebody who's watching, they may think or figure, okay, this might be it, this might not. What is it to look out for?
Well, the symptoms are not the same for every individual. Because these abnormal cells take over the bone marrow, the production of the normal cells is reduced. So you have reduced normal white cells. White cells are very important to fight off infection. So individuals can come down with recurrent infections. Red cells are very important for carrying our oxygen around the body. So hemoglobin becomes reduced. So features of anemia, tiredness, headaches. Platelets are important for making sure we clot adequately. So if you have reduced platelets, you have easy bruising, nose bleeding, bleeding from the gums. So these are some of the subtle signs. Of course, generally feeling tired, headaches, weight loss, night sweats, they're all symptoms.
So on discovering that one has some of these symptoms and going for checkup, is it then easier to catch it after you have gone to a doctor to have some of these symptoms and say, I think this and this is happening? Is it easy to catch?
Yes, if you go to your doctor and you complain of one of these symptoms, ideally the doctor will ask for a full blood count, which now looks at all the cells in the body. Based on that, we'll be able to see that some of the parameters are not within the normal range. And then we further go ahead to look at what we call a peripheral film, which is just looking at the cells under the microscope. And we'll be able to tell that they don't look normal. Their morphology has changed. Based on that, some are very straightforward. We can say straight away that this is a leukemia, and we can even give an idea of what type. Others are not so straightforward, so we'll actually order further testing. But the first process is actually a blood film and a peripheral film, and thereafter we can suggest more complex tests like a bone marrow aspirate or further molecular testing.
Okay. And are they curable, or is it all about management? And as far as the different types are concerned, you can walk us through each.
Well, like I mentioned, there is one, the CML, that we know the cause. And as a result, we now have a medication that's targeted therapy for it. So if you take that medication, fine, it's under control. but you have to take that medication continuously. There are certain types of acute leukemias as well, which if caught early, given treatment early, and they're the good prognosis type, they can be cured, yes.
All right.
Yeah.
Okay. So in terms of management, what gets into it other than medication, and also the kind of treatment that we see, there's the heavy cancer treatment like chemotherapy that we've heard about. Would you talk us through some of the treatment? Is it readily available here in Kenya?
Yes, chemotherapy remains the mainstay of treatment. Medication is available in Kenya. And now we do have a lot more medical oncologists as specialists. We have a lot of cancer centers that have now opened up in Kenya. So, I mean, the medical fraternity is focusing on coming up with improved management, more evidence-based management for leukemias.
Yeah.
So yes, chemotherapy is available locally.
Yeah.
You know, we've even come up with cancer guidelines now. So for every different type of cancer, the treatment has been outlined by specialists. So we hope that across the country, treatment is now uniform.
Treatment uniform across the country. Interesting you say that, because I was just going to ask you, in as far as, you know, having it in the various counties, because most of the times we find that these facilities and centers where this specialized care will be offered is in the bigger towns, mostly here in Nairobi. Do we have around the counties at least services, and, you know, if chemotherapy services and the other kinds of treatments that will be found?
Of course, because cancer still remains very specialized, we would like to keep treatment at the specialized centers. But what these guidelines also do is that for the clinicians out there, it gives them, you know, there's sort of a framework for them to know when to refer a patient. The reason why we try and keep treatment in specialized centers is because there's a lot of supportive care that's also involved. It's not just giving chemotherapy. One has to make sure that there's enough blood support, because patients require transfusions.
Yes.
They are prone to infection, so the availability of antibiotics. And of course, most of the specialists do tend to be in the cities.
And where does radiation the therapy come in? Does it go alongside chemotherapy, or is it a whole different story?
For certain cancers, radiotherapy remains the mainstay, and that's usually for cancers that involve solid organs. For leukemias, it still tends to be chemotherapy. Yeah.
And this is expensive. The medication, the treatment, the chemotherapy, it continues to be expensive, right?
Certain chemotherapeutic drugs, yes. Of course, the newer drugs on the market, because they are new, they are more expensive than the older generation drugs that we do have. But there are lots of groups who do support cancer treatment. For example, the CML that I was talking about, it was a free medication for patients who had that cancer.
Right.
So once they get the diagnosis, they get enrolled into a program which is sponsored, and they can get the medication at free or a subsidized cost.
But there could be side effects to these treatments. How are this managed when someone develops side effects?
I think it's very important that if a patient has been diagnosed with leukemia, their doctor needs to, of course, take them through the treatment process, the cycles of chemotherapy, and the duration that they're going to be on the chemotherapy for. Side effects, yes, are present. But I think if patients are aware of the side effects that they're going to experience, they'll be more positive towards accepting them. Unfortunately, I mean, of course, as we improve treatment, we make it more targeted, meaning that we aim specifically just for the abnormal cells, and we try not to damage the normal cells around. As we get more targeted, side effects are reducing, but they've not been completely eliminated.
Okay. How prevalent is it in Kenya? Do we have many people suffering from leukemia?
I think it is prevalent. There is a seasonal variation, especially in the colder months. We do see it a lot more.
Why is that?
I just think maybe that the symptoms come to light during the colder months. I don't have scientific evidence or a scientific explanation to that. Yes, yeah.
Okay, and who is affected mostly? Because we'll talk about this shortly, about the children, and this being, I understand from just some reading, that one of the most, rampant cancer among the children. But who's most affected by leukemia?
We see it in all age groups, actually. The chronic leukemias tend to occur more in the elderly population, but the acute leukemias can occur across the board.
What about the children? How different is it? How complicated does it get? More delicate in as far as the information that needs to be put out there, and also the kind of treatment that the children undergo? Because I'm thinking chemotherapy for the kids, that may be a little bit too heavy.
No, I mean, chemotherapy, it's specially designed for the pediatric population. Leukemias in children, actually, there are certain leukemias that do very well. And if they respond to chemotherapy, that is, if they're the good prognostic type, they can even be cured. So I don't think that parents should believe that once or if their child is diagnosed with leukemia, that's a death sentence as such. Leukemias can be cured in the pediatric population.
Okay. How young does it go for the children as far as those who will get contract leukemia?
We've seen it even in young infants, 6 months.
Wow.
Yeah.
And so because for them, I'm asking that it's more difficult for them to be able to express what it is they're feeling. They'll cry all the time. So I guess then it comes back to the medical professionals to be able to catch it and investigate what could be going on.
Yeah, mainly it's failure to thrive. They're not gaining weight. They're not breastfeeding adequately. They're always hospitalized, running a fever. Those are some of the signs that can point towards a leukemia.
And cancer in modern day has become the various types. It's crazy, killing very many people. Why is it, in as far as the research goes, and Kenya, not only with leukemia but with many different diseases and conditions, that has been a wanting area in as far as just weighing in and having professionals and experts study and get to understand the different ailments or diseases we're dealing with. You see a lot of that coming from Western countries. Why is that? We have that disparity, and also that would still have, in this day and age, a disease that is unknown what causes it.
Cancer, leukemia, is very complex, and I think in the last decade or so is when we're actually beginning to understand the pathophysiology or the mechanisms underlying the disease process. We have come a very long way, I assure you.
How so? Because someone will be like, huh?
Well, 10 years ago, we didn't even know that of the certain genetic abnormalities that we do know now. We can say, we cannot pinpoint right down to the genetic abnormality, but we can say that it's a combination of these genes or a combination of these mutations that can cause this type of leukemic process. A lot of studies are being carried out to determine, okay, if this is the abnormality that is detected, what treatment can we now start introducing to target those particular abnormalities? I mean, with CML, up to 10-15 years ago, it was standard chemotherapy, but now, because we know what has caused it, it's 1 tablet a day. Your question about why is Kenya behind in terms of research, I think a lot of our oncologists are actively involved in research. With the patient population that they have, there is a lot of publications going on in medical literature. Whether that translates to the public, I think we're getting there step by step. I mean, by them coming up with cancer guidelines, coming together to see what they can do for the country, I think slowly we are moving in the right direction.
Roughly how many oncologists do we have? Because that's the other thing with some of these diseases, having very few experts that would be able to attend to the patients.
I don't know the exact figure, but I do know that they are
substantial.
There are quite a few within Kenya, Nairobi mainly, Eldoret. There must be about at least 20 to 25.
Is there enough attention to leukemia itself? We have a breast cancer awareness month, and there's different diseases will have their days or months. Is there one for leukemia?
There is. Is it as highly popular or how do I put it, as
has attracted attention
as breast or prostate? Maybe not as much. I think maybe we do need to do a little bit more. This is one of the forums that hopefully will be able to sensitize the public. There are a lot of support groups available, but they're not, there's not much hype as there is for breast or prostate, not yet, at least.
Then in some of the treatments, there's bone marrow transplantation. Talk to us about when it gets to that level, when one requires to have that transplant. Why is it? At what stage are they for a transplant to happen?
Transplantation is mainly needed for patients who have what we call an intermediate or poor prognostic type of leukemia.
You have now really used some deep medical terms there. Break it down.
Yes. Well, what happens is that when a patient is diagnosed with leukemia, ideally there should be tests done to be able to tell how well is this leukemia going to respond to treatment. And that's when we talk about prognosis. There are those which have good prognosis, meaning that if we give the patient chemotherapy, it will get rid of the leukemic cells. Now, there are those dependent on the genetic interactions that I was speaking about. They have a poorer or an intermediate prognosis, meaning that chemotherapy may not be 100% effective. These are some of the candidates for stem cell transplant. So not everybody needs to have a stem cell transplant as is thought. Some will do just very well on chemotherapy and that's it. Others may need that stem cell transplant upfront and early. And usually there's tests that we can perform in the laboratory to be able to tell the doctor and the patient that, look, you are not going to do so well on chemotherapy, start considering preparation for a transplant.
Okay.
So it depends on the prognosis.
But for the transplant, then it's, would you say, a good way to go in as far as this, dealing with the whole problem, having a more clear outlook in as far as treatment and management of leukemia is concerned?
Yes. If you're not going to respond to chemotherapy, then yes, transplant is your best option.
Is the best option. What about the follow-up care? Because there's a lot of medication, there's a lot of those procedures like chemotherapy that you've mentioned, and for many people it is lack of that understanding that after this has happened, that's not the end of it. To ensure that this does not come back or you don't continue to suffer, there's certain things you must do after hospital visits. What is the key to keep in mind for that?
Exactly what you've said, that patients should not think that
I answered my question.
Yeah, that they shouldn't think that once they've had their dose of chemotherapy and they've finished their cycles of chemotherapy, that's it. I mean, even patients in whom the cells have been obliterated from the bone marrow, they're no longer present, they still have to have regular checkups done. They still have to have regular bone marrow examinations done, and even certain molecular testing done, so that we are able to detect what we call any residual disease. The idea being that if even 1 or 2 cells crop up, we deal with it quickly and efficiently before it flourishes into 1,000 cells.
Yeah.
So follow-up is key.
Follow-up is key. 50, 60 years ago, many would argue these were not the kind of conversations people would have, leukemia. Where did this all begin? Where is it a lifestyle? What is it about life now that we have so many of these cancers?
I do think it's our lifestyles. I don't have any scientific evidence to back this up, at least not yet, but I think in the near future there will be evidence. What we eat, the chemicals in our food, all the radiation that we're exposed to. And I also think that now we have better diagnostic testing. I think when a patient comes into hospital with even a minimal symptom, because they're worked up through lab testing, some of these conditions can be picked up earlier. I think maybe 50, 60 years ago, it was only caught when it was at its final stages. And now with the focus on more preventative medicine, I think we're picking up the conditions earlier as well.
Yeah. Speaking of preventative, in cases where, because you've said there are some cases where it's not known what will cause it, when somebody has a loved one in the family that has leukemia, are there things they can do to prevent it from, to prevent from getting it as well?
Well, they do say that if you have a loved one or a close family member with leukemia, your chances are higher. We don't have any screening tests as such for leukemia, which is unfortunate. But
why?
Well, we still are understanding what causes it.
Wow.
So once we understand, then we'll be able to tell this is the trigger. And once we know what the trigger is, then maybe we can say if we screen the population for this trigger, we'll be able to catch you early. But as of now, it's just primarily based on the symptoms that one has, regular checkups, good lifestyle.
Speaking of good lifestyle, again, nutrition, especially for one with leukemia, are there do's and don'ts as far as what they're putting into their mouths?
Ideally, you have to maintain a healthy lifestyle. Healthy meaning that you have a balanced diet. You're not indulging in excess of red meat or alcohol, just the basic steps. There's no one particular diet one could prescribe for patients with leukemia.
Right.
Just balanced, healthy.
Okay. Any misconceptions? I find that with most of these diseases, you'll find myths around them. People will think, oh, this happens because of the other. Have you come across any or heard of any?
I know that I think our patients still need a lot of insight in the sense that if one of their family members is diagnosed with leukemia, that's it. They don't want to seek any more medical treatment. To them, death has come, which is something that I think we should dispel. In terms of other myths, I think with the internet, with all the social media that we have, we need to create awareness. And we have lots of patient support groups coming up. So I will still say effort is being made, but more can be done.
When you say patient support groups, what are those for?
For patients who are diagnosed with leukemia,
come together.
Yes, fellow patients come together, just discuss their trials and tribulations and encourage others.
Okay. And the clinic trials, this in as far as doctors studying new treatments, how long has this been going on for, and what is used when you're talking about trying out medicine, trying out if this will work? What kind of research and how does that work?
Okay, there are a number of clinical trials going on, and that just basically trying new drugs on, acute leukemias mainly. So what happens is that when a new drug comes into the market, before it is approved for use as a routine medication, it has to undergo clinical trial. So if a patient has leukemia and there is no definitive cure, they are given an option. Do you want to enter a clinical trial? There's no guarantee, but it could be a success. Have there been successes? Yes. I think that's where most of our medical discoveries do come from. It is these clinical trials. Okay. Yeah. And are many people willing to undergo them? Yes. I think when they understand what's going on, what their treatment options are, especially if they're limited, they look at clinical trials as maybe a last hope. Yeah. And as far as also just enough information getting out on leukemia, the government involvement and what they're helping to leverage so that more people get an understanding, is there that coming forth? Is there that kind of goodwill, that kind of support, would you say, from government? I think there has been. I mean, in the past couple of years, we've seen a lot of our prominent politicians who come down with cancers, not leukemia per se. And I think that was sort of a stimulus in the right direction to, first of all, come up with our cancer guidelines. So yes, the government was supportive, is supportive. Obviously, I think we all still need to do a lot more. But I think with the right conversations, the right engagements, it's a step in the right direction. Yeah. What is for you, as we bring this to a close, is the most important thing that you feel, the most important piece of information to put out, coming across some of the most frequently asked questions? What do you hear and concerns that, the gray areas that continue to remain in as far as leukemia is concerned? What do you think is one thing perhaps you haven't said yet that is key to put out? I think that once a patient has been diagnosed with a leukemia, don't keep the questions to yourself. Engage your oncologist, engage your clinician, ask them what next, what are my options? Because nowadays it's not just, it's good for the patient to also understand what they're going to go through, because it is a process. It's not just medication over 6 months to a year and that's it. Even in those who have been cured, it's probably lifelong. So I would tell patients, ask questions, ask the right questions. Don't keep quiet. There is a lot of information out there, but if you don't ask, you may not hear of it. It is a killer cancer. It can kill fast. It can kill. It can kill. When you say lifelong ailment, most people are forced to live with it. Yes. And how can one still have a normal life? Healthy, or is it a lot of hospital visits, a lot of treatment, a lot of interruption to per se a person who does not have leukemia? I mean, again, it depends on the type of leukemia. Now with the chronic leukemias, one can have a normal life. The acute leukemias, again, depending on which type, depending on how severe it is. Obviously some have a difficult time, some will succumb. But in those who have a good disease type, hospital visits unfortunately remain, the close follow-up remains. So there is a little element of interruption to one's life. Yes. Okay, thank you, Dr. Ruchika Koli, for talking to us this morning. Asante sana. Thank you for all the information on leukemia, and I hope you've been able to get one or two things that perhaps you did not know about that disease. And before we bring the show to a close this morning, just want to read some of your feedback and begin by saying thank you so much for all the great tweets on welcoming me back. I appreciate that. A lot of welcome backs that are happening here. Ferdinand Omuga saying, Oguma saying it has been a long time. And thank you for the welcome back, Georgia Yeko. While you were away, James Smart took selfie photos with Joy during Bira. Nice. Yeah, I think I saw one. I saw one of those. Very nice. And somebody says, while I was away, James did not shave his beard. Yeah, it's his style. You gotta have your own style. Leukemia discussion. Somebody talking about what we've just been talking about in our health segment. Thank you, Abel, for watching.
Sidonge Olunga, you're saying that it's disappointing that government should wait for officers to die to treat them with some decency. And this bouncing off of the conversation we had earlier in the way it is, and in as far as the welfare of police officers is concerned. Mwinzi, you are talking about the lawyer, and you mean Ambrose Weda can make a good teacher, and the two of you can be good students. You are good to listening to this morning. Asante Sana, and Eid Mubarak messages as well to all the Muslim brothers and sisters. Indeed, today that sighting of the moon happened yesterday in various locations, and although the public holiday is tomorrow, Muslim brothers and sisters are marking it today, and so our best wishes, love to all of them. It has been a month long of sacrifice, of prayer, fasting, and indeed great to have brought it to a close for them in this day. Welcome back, George. Thank you. Nice show for such a wonderful Morning Express. Junior Omondi, you say. Again, Elvis Mbugo, love the show this morning. Very refreshing for a Monday morning. Yeah, don't we all need something good for a Monday morning after the weekend? Another news, Ronald Ngala is thinking that whether he's a joker. Only talking about what his comments on Obama and whether he should visit Kenya or not, and what he said that only goes to ascertain that some laws. Okay, I shall not continue reading that one, but he says, how is Obama beholden to us is the question Ngala is asking. And yeah, many people would ask, he doesn't owe us anything. Some argue he does. His father was born right here. He should at least visit before the end of his term. We'll wait. We are watching. 2016 is fast approaching. Will he visit? Will he not? We'll see about that. But of course, very many Kenyans and Africans will be traveling to the United States. Some already there for that international conference that is happening there. Derek Nzomo, welcome back. Great young uncle. I like how you call me young. Maybe I'm very old. George Kisundi again, loving weather sentiments. You guys have made me hooked on the show. Eric Ashanda, you say interesting discussion. Uncle Barry is so mean. Asikuja, okay. Some of you don't want him here. Welcome back, Mr. Vibe and Swag. Do I have swag? Arsenal FC, welcome back. Okay, thank you for all the welcome backs and the misses. I missed you too. It's always a delight to be part of your morning. Let's see. Ambani, you say, I have a feeling that the current government is on our necks. How are they on our necks again? Sikunjama Duke Gatangashire, you say. Asante sana, Sikunjama to you back. Sarah Dolly, among the very beautiful, wonderful people saying welcome back, thank you. Then there's, I remember serving the great lawyer T at Aroma restaurant. Great. And now you're watching him on TV. Isn't that amazing? Somebody thinks there should be a shift on our panel. We'll see about that. Welcome back. Wow, and many, many more. Glad to see you. Yes, I missed you too. How short was the leave? It wasn't very short. Monari, you ask. 3 weeks. Felt like a month there, but it's good to be back. Sophia. Somebody is calling and just ending it there. Yes. Let's get more. Karibu. Wow. And director, there's just lots of the welcome back, which I feel very well received. Thank you, guys. It has been awesome to be away on break. Always good, very important. Everybody needs a break once in a while, but also good to be back. Mornings, I'm excited to continue enjoying with you our mornings right here on Morning Express. We'll continue to have great discussions for you. And of course, if there's any topic you'd like discussed or any person you'd like to see right here on our morning couch, do tweet us at James Smart, at Sophia Wanuna, # Morning Express, and we'd love to bring them for you. Of course, tomorrow, because it's a public holiday, we're not going to be here, but we're back Wednesday morning. So we'll see you then. Enjoy the rest of your viewing. Stay with KTN and have a blessed day.